All right. Good morning, everyone. Welcome to our GIST Day of Learning, Pennsylvania for 2021. We are so grateful to have you join us here today. We want to thank our sponsors, Blueprint, Decipher, Genentech, Novartis, and Pfizer for making our GDOLs possible throughout the year. And we have quite a few coming up in 2022 as well. But just want to introduce myself. My name is Diana Nieves. I'm Senior Director of Outreach and Engagement here at the LifeRef. And I'm joined with Laura Acuzzi, who is Senior Vice President of the LifeRef Group. So over to you, Laura.
Thank you, Diana. We are anticipating additional people to join. So we thought we'd just get started with the introductions and just maybe give it a couple more minutes because we do have a number of people that have registered. Good to see you, Debbie. Good to see you, and Georgia, you as well. We have two wonderful physicians with us today, and we did say a few minutes ago that we have serious girl power this morning, ladies. So first, I'd like to introduce Dr. Melissa Burgess from the University of Pittsburgh and a sarcoma specialist, and Dr. Annette Dunsing, also University of Pittsburgh, and a pathologist. They will be presenting today. So we'll just give it a couple minutes, Diana, to have additional people jump on. I'd also like to thank Diana for her time and effort that goes into pulling together all of these educational events. We are having a big one this summer in New Orleans. It's our, every 2 years, we have Life Fest, which brings together between 100 and 200 patients and their families, as well as members of the medical community from all over the world. So we're looking forward to that. We've had to cancel it because of COVID. So we're certainly hoping that we're going to be able to do it in the summer in New Orleans. So with that being said, Diana, I guess maybe we'll just give it a couple minutes.
Sure. It's quite interesting because of, when we were first hit with COVID and people were indoors, we would sell out. We'd have like 100+ people participate in these events virtually, but I think a lot more people are getting out and doing things, and we're definitely seeing the need to move to shift to face-to-face.
Yeah, sure.
Yeah.
And it's a busy time of year. So
Yes.
But we're still grateful that you're doing it.
Oh, absolutely. Absolutely.
Yeah. And we try as much as possible to record these and share them with our members. So whoever's not here in person definitely will get to see it.
Would you like me to share my screen or not yet?
I guess we can start. People will jump on.
Or I could share it and just wait a couple minutes or whatever you want to do.
Whatever you want to do, Diana, it's your call.
Yeah, I think we can start. And as I said, we're recording this so we can share it with our members, and hopefully more folks will sign on as we move forward with the day.
I'm not sure if you can see that though.
Yeah.
Yes. Yeah. Yep. We can.
That looks good.
Excellent.
Yes.
Awesome.
I love that you captured our logos.
I really like this just Day of Learning Pittsburgh background. It's really nice.
Yeah.
Oh, I love that too.
Yeah, me too.
Are those bridges, are those two bridges that go into Pittsburgh, or was that just part of our design team being fancy?
Bridges are our thing. We have like 700 bridges.
Do you? I've never been. I want to go. I do want to go. Maybe we'll do a live event soon.
Yeah.
So that was good to capture those bridges.
Yeah, absolutely.
Yeah, the person knew what they were doing.
Okay, good.
Definitely.
Do you think I should start then?
Yeah, that would be excellent. Thank you.
Okay, great. Well, good morning, and I'm doing this presentation from a rainy Pittsburgh morning here. I really appreciate the opportunity that the Life Raft group has given me and Dr. Dunsing today to go over some education on GIST. And I do recognize that, well, this is my first time participating with the Life Raft group, so far is excellent. And I recognize that people that are listening to these may be experienced, or we might have people that are newly diagnosed. So I was kind of asked to sort of go over an overview and current treatment options. So some of this may be basic, but I think it's always kind of good to review. All right, so let's go over what GIST is. We know that it's a rare connective tissue tumor of the GI tract, which is totally different than regular GI malignancies that we see. So it is kind of less than 1% of all the different cancers that we see in the GI tract, all the way from your mouth all the way down to the bottom. We do know that GIST is a sarcoma, which is a specific type of cancer of connective tissue, and basically starts from different types of cells, not the epithelial cells, but the mesenchymal cells. So it is connective tissue. We also know that this is a rare cancer where it's only affecting about 5,000 to 6,000 new patients each year in the United States, which is not very common. Mostly this is affecting patients diagnosed between the ages of 50 and 70. And we have an estimated annual incidence of 6.8 to 15 cases per million. Typically, we see that there is an equal number of male to females that are being diagnosed with GIST each year. We also have an understanding of where GIST sort of comes from in the GI tract. We know that the cancer arises from the interstitial cells of Cajal, which are kind of like the pacemaker cells of the GI tract, kind of pushing all of our food and nutrients throughout the GI tract. We know that over half of the cases start in the stomach, but really GIST can be seen anywhere in the GI tract. And the second most common place would be in the small intestines, then the colon and the rectum, and then less than 5% in the esophagus. I didn't include it here, but sometimes we see an extra GI tract GIST, which is I consider one of those ultra rare type of things, but that also happens. Most often patients would present not really in one particular manner. I mean, really it could be a whole host of different things. Pain or discomfort in the abdomen or abdominal fullness is a possible presentation. Sometimes the GIST tumors, as they're growing, start causing bleeding in the GI tract. So patients can present with anemia or low hemoglobin, red blood cells, or have blood in the stool. Sometimes these are actually just found incidentally at the time of surgery or on a CT scan as a mass. And unfortunately, sometimes patients present with a bowel obstruction. I included a picture here of a GIST here. I don't know if you can see my cursor, but I'm just kind of highlighting that this is a gastric GIST and the lesser curvature that was seen. Basically, the mainstay of treatment is to try to remove it with surgery. And in about 2/3 of the cases, the primary tumors are resectable. But unfortunately, 40 to 90% of the patients would recur. And that mostly occurs in the liver or in the abdomen. But GIST can also occur in other places, such as the lungs or the bone or other places. There's different types of GIST, and we're learning more and more. So here I actually put two different pictures up, and I think you can tell that these are actually quite different. And so many GISTs are actually spindle cell type, which are more cigar-shaped, sort of longer cells. And on the right-hand side, we see epithelioids type, which is more of a round cell. And sometimes GIST can actually be a mixture of both of these. We also learned that, and this was a major breakthrough, because back in a long time ago, in the early 90s or 80s, we actually could not really recognize the GIST from other types of tumors, such as like smooth muscle tumors. And I know Dr. Dunsing will probably touch on this a lot because she was involved in this research, where basically we found out that in the majority of the GIST patients, that KIT, which is a basically like a growth factor, stem cell growth factor, was overexpressed in GIST in many, many cases. So these are just some examples under the microscope where the GIST is staining very brightly for KIT. And in other cases where KIT was not overexpressed, we developed, the pathologist can also check another type of stain called DOG1, which actually stands for discovered on GIST1. And so that's also expressed in a majority of tumors. So expression and actually having mutation are a bit different. And so in the majority of cases, we will find that there's also an actual mutation or basically a mistake in the DNA in the KIT gene. When the expression, or you can actually see the protein on that stain is positive in GIST. And when we look into this further, we notice that most of them are actually happening in the exon 11, which is in 75 to 80% of cases. Less common, they will involve exon 9, and then rarely you can see exon 13, 14, 17, 18, etc. These are actually activating mutations, meaning that they're sort of turning the cell on to continue for cell growth. Additionally, in a small number of cases, we would see that the platelet-derived growth factor receptor alpha is mutated in about 5 to 10%. And then in about 15% of cases, we will see that there's no KIT mutation or no PDGFR mutation. So we tend to call this wild type GIST. But we're learning more and more that the wild type GIST are actually several different types of mutations as well. This is a diagram kind of showing what is actually happening here. So basically, when you have a cell, this is basically outside of the cell where my cursor is, then you have the cell membrane, and then you have inside the cell, which is basically where the DNA is. And basically what happens is you have these ligands that come down and they attach to the receptor, and that's supposed to basically make the cell have a green light to turn on and for cell growth. Unfortunately, this is not supposed to be on all the time. It's not always supposed to be a green light. But unfortunately, when you have a mutation in different areas of this receptor, basically what you can find is that it's constitutively activated, which means that it's always on, which is not good. So most of the cases, 71% of the time, are in this exon 11, which is next to the membrane. And then sometimes you have exon 9, which is outside of the membrane. And here you can see in these the ATP binding zone, you can actually see that there are sometimes additional mutations in exon 13, 17, etc. What causes GIST? Most of the time, this is spontaneous or sporadic. But in about 5% of the cases, this will actually be familial. And so there is a genetic disorder called neurofibromatosis type 1, where patients would also develop neurofibromas, brain tumors called gliomas, and other types of sarcomas. But actually GIST is pretty common. So we know that in the duodenum, which is the first part of the small intestine, about 6% of the duodenal GIST actually occur in NF1 patients. There's another genetic syndrome called the Carney-Stratakis or syndrome or Carney triad, where patients can get a GIST in the stomach that is paired with some other types of tumors. And later research sort of realized that most of these did not have KIT mutations, that they actually had mutations in SDH. And so they actually do not respond to imatinib. They also tended to recur in younger patients, but the clinical course of the growth of the cancer actually tend to be more indolent or slow growing. There's also something called a familial GIST syndrome as well. So major breakthrough that happened with in the early 2000s, Dr. Dimitri and his team basically realized that with the KIT being constitutively activated in the majority of GIST, that they started using imatinib, which is a KIT inhibitor. And prior to all of this, before we had imatinib, unfortunately, patients that were diagnosed with this, even with surgery, they were only living for about a year. But once imatinib was started and they randomized patients to 400 or 600 milligrams, they realized that the survival was significant. So as you can see here in this graph, and I will tell you, oncologists love these Kaplan-Meier curves, so my presentation is just filled with them. But basically, when half of the patients, like here, when you have even at a year, which is where most of the patients were actually dying, even beyond the year, you see that the survival was just significant, and a significant amount of patients, almost 90% of the patients were still surviving on imatinib. So major breakthrough, high response rate, and this really was a huge practice changing type of situation. So we started studying different types of dosing in imatinib. We studied 400 milligrams and 800 milligrams, double it up, maybe that would be better. On patients that have exon 11, we realized that yes, the 800 did a little bit better, but it was fairly similar. However, the patients that had exon 9, they didn't respond as well to the 400 of imatinib, but they did much better at 800. So you'll see that physicians will often recommend a higher dose of imatinib for the exon 9 patients. So of course, when we choose our treatments, there are certain things that affect survival and our treatment choices. And the most important things are the tumor size. So larger the tumor, more risk, as well as a high mitotic index, which is basically the cells that are dividing or the growth rate. So a higher mitotic index is definitely a higher risk, as well as the primary tumor location. So stomach tends to have a lesser risk, but being where the primary tumor starts in the intestines, that's a higher risk. And then fourth, we also note that tumor rupture at the time of the surgery, where basically this means that cells have spilled into the abdomen during surgery, that's also a very high risk situation. So, what we discovered is that if you make a table here, and you look at the tumor size, the mitotic rate, and the location, that you note that there are some cases where you have a significant risk of recurrence. And so I sort of put in the red box cases where there is very high risk of recurrence, and we try to select out those patients that may benefit from earlier imatinib. And so that is why we started the study where we look at adjuvant treatment, which is basically starting imatinib after the time of surgery, after the primary tumor is removed. And this study had nearly 350 patients in each arm. One arm, the patients received 400 milligrams of imatinib for a year, and then the other arm, they received placebo, which is basically a sugar pill. And as you can see here in this Kaplan-Meier curve, that the patients that actually received imatinib relapse less often. So there was definitely an improved relapse-free survival in patients that received imatinib by 65%. So that was quite significant. So we decided, well, if 1 year is good, why not 3 years? And so they did that study. And they also saw that when you gave 3 years of imatinib, there was a significant improved risk of recurrence by 54% compared to 1 year. So we tend to select out patients, like I said, that would benefit because as many of you know, imatinib is not, completely benign. I mean, it is a drug and it does have side effects. And I know Dr. Dunsing is going to touch on some of those side effects. And so we want to try to select out the patients that would benefit the most. So those are the patients that have the higher risk features, such as the large tumor size, the small intestines location, high mitotic rate, for example. Now, of course, there are ongoing studies to look at 5 years versus 3 years. I saw another study being done in Europe where they're looking at 10 years, kind of like just following patients. And if you talk to many oncologists, you'll find that each case comes down to a physician-patient discussion. And there are some instances where a physician may say, you should probably just continue this if you're doing really, really well. But it's good to review this data. So sometimes before surgery, we would actually consider giving imatinib. And this is a case report that we published at the University of Pittsburgh, where we had a patient that had a very large gastric GIST primary that was actually tested with a biopsy and had molecular testing that did show an exon 11 or an imatinib sensitive mutation. And this is what the tumor looked on PET scan. And it was very, very bright on PET scan. What this patient did was underwent 6 months of neoadjuvant, which is pre-op imatinib therapy, and there was a significant reduction in the size of the tumor. When the patient went to surgery, as you can see here on the right part of the PowerPoint, that basically there was a nearly 100% response to imatinib. That what you're seeing on the left here is basically no viable tumor cells. And on the right-hand side, they found a very small patch of some spindle cells, but this was less than 5% of the tumor. So this was really quite significant. And unfortunately, the guidelines for using pre-op imatinib are not really well defined, but I will say that in multidisciplinary discussions and specialty centers that treat GIST, that this can be used to optimize response, and especially for large bulky tumors. So that's really great. We know that imatinib is fantastic, but it doesn't always last forever. And so unfortunately, 50% of patients will have progressive disease at 24 months, which is 2 years. And basically, we have an understanding that progressing disease often develops, at least in one way, to secondary mutations that happen in different parts of the KIT gene, so of the receptor. So basically, you have mutations in the ATP binding domain and also the activation loop of KIT. And unfortunately, these are areas where imatinib is not going to be helpful. So they started looking at some other types of drugs that potentially could help our patients at this stage. Now, of course, there are cases where a patient could be on 400 milligrams of imatinib, but have some progression. And certainly there are certain instances where you could even consider increasing your imatinib to 800 and seeing a response. However, we do have some other drugs. And I think one of the things that I definitely recommend, and many other GIST oncologists would recommend, is that you should try to repeat tumor sequencing. So you're looking at, for new mutations, those secondary mutations that have developed. And this is really important because there are definitely strategies that could be used based off of what this sequencing shows that can help physicians make a choice. And this can be done by actually biopsying areas of the tumor that have progressed, or you could do what's called a liquid biopsy, which is looking at the peripheral blood or the circulating tumor DNA, essentially. So that's when sunitinib came in, and basically we had 312 patients that were randomized to receive sunitinib, which is another one of these tyrosine kinase inhibitors, small molecule drugs that that was active. And as I showed you, when they tested cells that had imatinib resistance, and this trial was randomized also to placebo. But as you can see here in another one of these Kaplan-Meier curves, that the patients that had sunitinib had a significant improved. Basically, they didn't progress as often as the placebo patients. And so because of this major phase 3 trial, sunitinib was actually approved for second line after imatinib resistance. After sunitinib, we then started studying Regraphenib, which is another one of these tyrosine kinase inhibitors. And there was a phase 3 trial that was really quite extensive with 57 hospitals in 17 different countries. And again, this trial was also randomized to a placebo, but these are patients with GIST that had already received imatinib and sunitinib. And so they received Regraphenib at the 160 milligram daily or placebo, and they also had really good supportive care. And as you can see here, that after months on the drug, the percent survival was significantly less for the placebo than it was for the Regraphenib patients. So in here, the risk reduction was nearly 70% for these patients. If anybody has any questions, please feel free to also interrupt me. I realize that as well. But I'm just kind of moving through here. We can also do questions at the end. So later on, we realized that maybe with those other drugs, and Sutent and Regraphenib are actually, quite toxic. They have a lot more side effects, I think, in terms of imatinib, although every patient's a little bit different. And so scientists started looking at different ways that we could target this KIT receptor. And so because imatinib is resistant to these other sort of exon mutations, that's when Regraphenib came in. And basically Regraphenib, it has dual action where it can actually work on the receptor at different places where imatinib cannot. And that is really significant because we could actually treat patients with a broad range of KIT and PDGFR mutations. And so therefore, this drug was studied in a phase 1 initially, and then later in a phase 3 study, also randomized to placebo, where patients did not progress on average, like the median, at 6.3 months compared to 1 month with placebo. So this was also a major breakthrough, and in May of 2020, Avapritnib was approved for fourth-line GIST. And even though the response rate was not super high, it did prevent progression, which was important. Patients that were not able to, or initially responded to the Avapritnib at the 150 milligram daily, then there was an option to do an intra-patient dose escalation where they actually increased the dosage to twice that, kind of like what we did in imatinib initially in our studies almost 20 years ago. And we did see that patients did achieve additional benefit when we doubled the dose. Avapritnib was also a recent drug that was studied around the same time as Regraphenib. And this is another type of fancy KIT inhibitor. And essentially, in our earlier phase studies, this looked very promising, which led us to start a phase 3 trial in the third or fourth line GIST versus Regraphenib. So here we have a study that is now not randomized to placebo. It is randomized to a standard. And unfortunately, this was a negative study, so it made a lot of us sad. But what you see here is actually the patients that had Regraphenib, which we knew worked pretty well, actually did a little bit better than the Avapritnib. What's nice is that we did figure out that there was a subset of patients that had this imatinib resistant mutation in exon 18 of the PDGFR gene and the D842V mutation that essentially had a significant response rate. In fact, 88% of patients responded, 49 out of 56 patients. And at 1 year of therapy, 70% of patients had not progressed. So this was very exciting. And so even though it was not successful in a larger group of GIST patients, this was approved in January of 2020, specifically for the PDGFR D842V mutant GIST. And this was great because we didn't have basically a huge unmet need for these patients. So I took this sort of algorithm from, which I think kind of highlights essentially what physicians are looking at when patients have advanced GIST. We definitely want to look at the mutation status. And if patients have a D842 mutation, we would put them on Avapritnib. If they have a KIT mutation or a non-exon 18 PDGFR mutation, imatinib would be our first line choice. And of course, there are select patients that would have a response where we could consider resecting some of the residual disease or metastatic disease, especially if it's not, if it's minimal. But at the time of progression, in most cases, you would consider sunitinib, then Regraphenib, and then Avapritnib. Of course, clinical trials are always recommended. So there were several drugs selected, investigational drugs here. Of course, I am not highlighting all of the amazing GIST trials that have been out there, but there have been several phase 2 and phase 3 studies looking at some other types of inhibitors, including immunotherapy. And some of these have had some successes such as pazopanib or sorafenib, even ponatinib. And the Cabo-GIST study, which is more recent, also showed a median progression-free survival about 5.5 months. These are in patients that are heavily pretreated with those other inhibitors that I already mentioned. I think one population of patients with a huge unmet need is this SDH deficient GIST, which is considered a wild type GIST. And in these cases, as I mentioned before, they do not respond to imatinib. So we're still looking for new types of therapies for this patient. Fortunately, there's a new study through the National Cancer Institute with the principal investigator, Dr. George, who's studying a new type of small molecule kinase inhibitor called Regraphenib, which actually blocks a different type of receptor called FGFR. And so this is exciting because not only is it for SDH deficient GIST, but it's also for FGFR altered sarcomas. And this is now open across the United States, of course, including Dr. George's site at Dana-Farber, but I'm also happy to report that we have it open at UPMC so that we have a treatment option available for this unmet need of patients. Again, I only have 20 to 30 minutes reviewing basically all the different things that are happening, and it's hard to review all of the exciting research. But there is another study that I wanted to highlight that we will be opening at UPMC. And this is a study where we're looking at different types of KIT inhibitors. And there's a new KIT inhibitor that is also shown to sort of block areas that imatinib cannot. And initially, this was, I guess, a molecule that was studied by Daiichi Sankyo, but now Cogent Biosciences will be performing this much larger scale trial where they actually performed early studies looking at this new CGT9486 KIT inhibitor, adding it to sunitinib. And we're going to randomize it this time to sunitinib alone. But there's actually several parts to this. They're trying to basically build in a bunch of different parts in this huge clinical trial to learn a lot of new information. So I think that this is, just one trial that I'm highlighting that I think is coming down the line. It's not nearly touching upon all the amazing research that's happening all over the world. But again, I think it's good to see that there is some new research happening because we still have a lot of work to do. So basically, just to summarize, we know that imatinib is a really effective treatment, especially for patients with KIT exon 11 mutations. We know that size and location and mitotic rate, or the growth rate, predict risk of relapse in patients. So there are certain patients that we would select for use of imatinib therapy after surgery and sometimes even before surgery and after. We know that even though imatinib works fantastic, after a couple of years of imatinib, there are patients that will become resistant. And we know that sunitinib is used for second line, typically Regraphenib for third line, Avapritnib for fourth line, now approved by the FDA. And of course, I didn't touch on this, also not time to do that, but sometimes we use local therapies such as surgery, ablation, or radiation in select cases, especially for patients that have limited sites of metastases. And of course, newer therapies are being researched. I think one thing to really highlight in some final thoughts is that it's really important to be referred to a GIST specialty center where you have physicians from multiple disciplines that really understand GIST, how it works, and what are the new treatment options to help improve outcomes. Of course, I can always stress lots of clinical trials as we need to learn more and more information for patients. I think it's important to test for molecular changes in the tumor that help guide certain treatment options. And of course, we need to collaborate and we need to work on better clinical trial design. And I think it's about time that we stop randomizing to placebo, which I think was a major thing that was highlighted this year at our CTOS 2021, that we need to stop doing that. And that's all I have for today. So I didn't touch on everything, but if you have questions, happy to answer them. Thank you very much.
Okay. If no one has any questions right now, there will be an opportunity at the end to ask questions.
I have a question. How often do, Dr. Burgess, do you recommend CT scans or PET scans?
That's a great question. I think that when I get a patient started on a new therapy, I think it's important to have a look after a couple of cycles. So that could usually be about 2 months of treatment, sometimes up to 3 months, but it depends on the patient. I think that the big question, PET versus CT, is an ongoing thing. I think that PET scans can add something, especially if you have a very strong metabolic tumor on PET scan. You can actually do a follow-up to see if there's not only a size difference, but also a metabolic change. So what you're hoping to see is that the tumor is less bright on a PET scan. So sometimes that can be utilized. Unfortunately, insurance companies won't really allow a ton of PET scans. So it does turn out that CTs or even MRIs which have no radiation could also be very useful. But yeah, I usually would only allow a patient to be on a drug for a couple of cycles before we would check that. Now, there are cases where you may have a mixed response, where you may consider, once you take an early look, to perhaps, if there's some signs of maybe early progression, you could even continue for a couple more months and before you make your final decision about what the drug is doing for a patient.
Okay.
Yeah.
Thank you.
Yeah, sure. One other thing I would just stress is, I think one of the things that I noticed is that sometimes there are certain physicians that don't have an understanding when you're measuring response to certain drugs and GIST. Oftentimes we standardize in our clinical trials, we use something called the RECIST criteria, and we look at the size differences in a 2-dimension. And I think it's important that, especially when this is in normal practice, to take into consideration what is the density of the tumor, because even if there's some slight increased growth in the tumor, it's possible that the density, that the tumor is actually liquefying in the center, and that actually could be a sign of response. So I always take that into consideration as well.
Thank you. And how would I know if I become imatinib resistant? Just through a CT scan or something like that, or a PET scan?
I think that that's typically how it starts, where you start noticing some growth. And the problem is that we use a term called heterogeneous, which means that if a patient has several tumors, it's possible that certain mutations are developing at different times. So you might see that if a patient had 3 tumors, you may see only one that is starting to grow. And so I usually would take into consideration, like I told you, the density, repeat scans. And if you see a trend over time that there's definitely disease that's progressing, one thing that you can do that I stress like in my presentation is to retest the patient for molecular testing. And perhaps if a patient started with exon 11, which is sensitive to imatinib, if they developed an exon 17 mutation, then you can kind of get an idea that the patient, that the tumor is becoming resistant to imatinib because it's developing those other mutations.
Okay, thank you.
Mm-hmm.
You were very helpful.
You're welcome. So I guess should I stop sharing so Dr. Dunsing can?
Excellent.
Fantastic.
Yeah, so let me see how this works for me now. I'm working off of 2 monitors here. Does this work for everyone?
Yes, we can see the slides.
You can go to display settings at the top there. That way you can get out of your presenter mode.
See, actually, let me stop. And
I was gonna say you can go up to the top display settings.
It's not at the top. Is this better?
Mm-hmm.
Yes.
All right, it somehow switched. Maybe it's not better because I can't go back and forth.
You start your slideshow
Yeah,
I can
maybe.
help you. I've watched enough of these virtual things by now, right? Like we all have. Try to help each other. There you go.
No. Okay. So that doesn't seem to work either. Sorry.
That's okay.
Let me stop share again. Yeah, maybe I should not do the two monitors. That's a new thing for me. So let me go.
Well, it's great to see more folks have signed on. Thank you for joining us today. For those of you that were in early on during our conversation.
Okay, one more try. Now, or do you still see?
Yay, success.
Looks great.
Very good. Okay, so as you can see, I did not capture the new logo for the Pittsburgh series, unfortunately, but I still do like it, and I did see it. So yeah, thank you very much to everyone at the LifeRaf group for giving me the opportunity as well to present today. It's the first time that I'm doing that with Dr. Burgess for the LifeRaf group, which is great. And I've talked to, about other topics at other LifeRaf group presentations. So maybe some of you know me, but maybe not. So let me start with a quick outline of my presentation. Let me get my pointer here really quick. Maybe also let me introduce myself a little bit more in more detail than Diana did at the beginning before it actually started. So I am a trained pathologist. However, for the past 20 years, I've strictly done laboratory-based research and almost exclusively on GIST. So I did my postdoc back in Boston. That was around the year 2000 and was actually there when the first patient was treated with imatinib, not in the room, but in the next building. After moving to Pittsburgh, I started or continued to keep working on GIST. And my main topic is to find new therapeutic strategies to treat GIST. Because as Dr. Burgess already alluded to, we know that although imatinib is a great drug and was a huge breakthrough, unfortunately, resistance occurs and we need to treat the patients that unfortunately come down with an imatinib resistant GIST. So in my first part of the talk, I'll talk about some strategies that we use in the lab to find new GIST therapies. And then in the second part of my talk, I will talk about a new area of research that I have started, and I could not do that alone because I am a pathologist and lab-based researcher, but together with my colleague, Dr. Robert Ferguson, who is a psychologist, and we are looking at cognitive impairment in GIST patients, the so-called Gleevec brain. You guys may have heard about it. And then I'm quickly going to introduce two research studies that we have ongoing and that you may be wanting to participate in. Okay, so let's start with the lab. And I mean, Dr. Burgess has already alluded to this, just essentially paved the way for targeted therapy and personalized oncology, because GIST was the first solid tumor that acted as a proof of principle that this class of drug, this new class of drug at the time, tyrosine kinase inhibitors, small molecule drugs that are taken orally, that they actually do work in the patients. So this was studied in GIST and a certain type of leukemia that is also amenable to that treatment. And we are just recently have celebrated the 20-year anniversary of the FDA approval of Gleevec for both of these entities. And here's a really very early PET scan of one of the first patients that was treated with imatinib. And before therapy, the patient had a huge bulky tumor in the abdomen. And after 4 weeks of treatment, this tumor is metabolically inactive. However, as we already heard, there is the big problem of drug resistance. And again, although imatinib does work great for some patients, even for a really long time, by the way, just as a little tidbit to give a little bit of hope to everyone joining here, I personally know one participant of the very first clinical trial for Gleevec. She unfortunately was in the hospice before that, and luckily got into that first clinical trial, and she is still alive and well now, today, after those 20 years. She has been on Gleevec all of these years and is doing great. So although resistance is a problem and we need to know more about how it develops and how we can target it, not everyone will experience it. As we also heard from Dr. Burgess, luckily we do have in 2021 4 approved drugs for just right now. Again, it started with imatinib. About 5 years later, we had the approval of sunitinib, and then in 2012, another sort of rough 5 years later, the approval of Regraphenib in the 3rd line. And then it took a little bit longer to get 2 more drugs approved, Regraphenib and Avapritnib. And Dr. Burgess already mentioned that Regraphenib is the standard 4th line drug for KIT mutant GIST, and Avapritnib was approved for the specific type PDGFR alpha mutant GIST that has this specific mutation. I'm not sure how it looks like in the clinic, and Dr. Burgess may later allude to that as well. Avapritnib does have, as we also saw from the plots that she showed, it does have activity in KIT mutant GIST. It's just not approved, but maybe it could be given on a compassionate basis. So all of these are KIT inhibitors, and why is that so? It is because KIT continues to be the main driver of the disease. And how do we know that? Well, let's look a little bit more at the molecular characteristics of the KIT mutations, and some of this has been discussed by Dr. Burgess already. Again, this is a schematic of the KIT molecule, this being the cell membrane, part of the molecule sticking out of the cell membrane, part of the molecule being inside of the cell, and most mutations being just inside of the cell in the so-called exon 11, and then the next more frequent being outside of the cell in where usually the ligand binds in exon 9, and exon 13 and 17 are not so much affected when the GIST is first diagnosed. Exon 13 and 17 code in the protein for what we are calling the ATP binding domain and the activation loop, meaning that this is where the action is happening with respect to KIT signaling. So an active receptor telling the cell to proliferate and to divide. And importantly, this is where most KIT inhibitors bind and thereby inhibit the action of active KIT signaling. However, the secondary mutations that confer resistance to imatinib all happen, or most of them actually happen in this region. And what this means is that imatinib cannot bind there anymore. And this is why the tumors are resistant to imatinib therapy. So that is depicted here with a red box. All of these mutations in this action center of the molecules lead to imatinib resistance. So as we heard, there are fortunately 2nd and 3rd line drugs that have been approved, sunitinib and Regraphenib, and luckily they are active against some of these mutations. So for example, sunitinib works really well against mutations happening in exon 13 and 14 in this region of the molecule. And Regraphenib is really excellent against mutation in exon 17 in this region of the molecule. However, you will see that it's sort of a mirror image. So sunitinib will not work on some of the mutations that Regraphenib is nicely working on, whereas Regraphenib is not so great on some of the mutations that sunitinib is active. So while this is all good, and as Dr. Burgess mentioned, mutational testing can actually guide us in the selection of the next drug, because obviously when we see a new tumor popping up that has a mutation in this region, then we would be more likely to give sunitinib as a next drug, and vice versa. With a mutation in this region, then we would give a Regraphenib as a next drug. However, there is unfortunately a problem with that. And the problem is that resistance mutations are heterogeneous. And they're not only heterogeneous between different tumor locations if a patient has several tumor nodules, but they can also be heterogeneous within a tumor. So one region, like within one tumor nodule. So one region of a tumor nodule have a predominance of an exon 13 mutation as a secondary mutation, and another region of the nodule can have a predominance of an exon 17 mutation. So that poses, unfortunately, a problem, because when we select a drug according to this mutational testing, it may work on some tumor cells and may not end up working on another subset of the tumor cells. So while I will not really argue against mutational testing in the imatinib resistant setting, we as clinicians and patients have to be able to see the limitations of that. A way to get around this problem could be, and we're hoping it will be, is the liquid biopsy, because liquid biopsy is sequencing for KIT mutations in the patient's blood. So these mutations come from tumor cells that are just shedded into the bloodstream sort of randomly from any part of the tumor, any tumor nodule. So looking at what we see in the blood should give us sort of the entirety of all the tumor nodules and all the mutations being around. Nevertheless, again, I mean, the pharmaceutical industry and some of the labs that look for new therapeutic strategies for just what they are focused on is for new strategies, finding better KIT inhibitors. Which so far has worked great, but there may be a time when this is not possible anymore. So our lab has asked the question, can we develop strategies that target KIT in a way, but that are not KIT inhibitors? Because we do know that the cells are dependent on KIT, obviously. So if we in any other way could cut out the KIT signaling pathway, we would equally be able to treat the tumor. So let's look at a little analogy here. So how do we turn off the light? So obviously what comes into mind first is, well, we turn off the light switch, right? But we could also remove the bulb. So that would also turn off the light. So in analogy, turning off the switch would be using KIT inhibitor in the scenario of the GIST. And so maybe removing the bulb could be one of our new strategies. So again, imatinib and other KIT inhibitors will turn off the KIT signaling, so turn off the switch. And what we might want to look at is maybe remove KIT altogether in the tumor cells. That should also lead to cell death. So to do so, we need to look a little bit at molecular biology and see how KIT is made. So as you all know, your DNA is your blueprint for all the proteins, all the molecules that are being made in your body. And the way that works is that this works through sort of a another molecule that tells the cells how to make the protein, and this is called mRNA. So the mRNA reads the DNA sequence and is sort of part of the blueprint, half of it, and then the protein translation, the translation machinery will make the protein out of it. mRNA obviously is now in all ears with a COVID vaccine, some of which are mRNA based. So this is a really small, but also really a short-lived molecule that is only supposed to be there at a time when you need to make new protein. So we actually have been looking into inhibiting these two processes. So say if we inhibit DNA transcription, so mRNA being made for KIT, that also should lead to no KIT protein being made. In addition, if we inhibit this step, the protein translation from mRNA to the protein also should lead to no KIT protein being made. And in the next few slides, I will show you that this is actually true and it works. So some of it was unbiased and non-intentional. We, a few years ago, performed a drug screen that included almost 100 FDA-approved compounds. And at that time, it was mostly chemotherapeutic agents, so more classical chemotherapy. And some of them actually do include transcriptional inhibitors. So what we found when we looked at the results, actually, we let the computer tell us which of the compounds were either effective or not effective in GIST. And LMS is leiomyosarcoma. This is just a control group of cell lines here. So when we told the computer to look at this effective drug groups and tell us which drugs these are, some of them, specifically these here, were actually inhibitors of gene transcription. For example, mithramycin A. And in some follow-up experiments that I'll show you in the next slide, we show that this actually works and how it works in GIST cells. We then actually tested another group of compounds that are derived from the mithramycin A and called mithramycin analogs, and these are also effective in our cell line models. So how do you do these? How do these transcriptional inhibitors work? So as I told you, we inhibit transcription, we inhibit mRNA from being made, and you don't really need to understand much here, but what we are looking at here is a specific technique called RT-PCR that looks at how much mRNA of a certain gene is there. So in our cell line model of human GIST, we can see an untreated cell, you see this white band, and there's KIT mRNA being made, but when we treat the cells with mithramycin A, this band is absent. So no KIT mRNA is being made, which leads to no KIT protein being made. So this is another technique that we are using that looks at protein called immunoblotting. And when we look at the KIT protein here in cells that have been treated with mithramycin A over a period of time, really quickly, actually, the cell stops making KIT protein. So you see no bands here, nothing. It also leads to reduction of KIT activity, which is shown here. And as a result of this, the GIST cells die. And importantly, we use two cell lines here, these two cell line models, and GIST 430 is a human cell line model that is derived from a imatinib-resistant tumor. And you can see here, after 72 hours, a lot of these tumor cells, almost 80% of the tumor cells are dead. So this is what we want to see. This drug kills GIST cells by reducing KIT protein levels, or initially KIT mRNA levels. We found later on, we found another way to target KIT transcription. This may seem to be a little bit counterproductive, because this drug, bortezomib, is a drug that is actually usually used to inhibit the cellular protein degradation machinery, meaning that some proteins actually pile up, but the protein transcription machinery that makes mRNA really needs this protein degradation machinery for transcription to start. So actually, these proteasome inhibitors inhibit translation. KIT transcription at the DNA level. And this is what we see here. Again, say when we treat our cell line models with this drug, bortezomib, we get less KIT mRNA made. We get less KIT being made. KIT activity is drastically reduced, and the cells die. These are, again, our just for 30 cells that are imatinib resistant. As you can see here, with if you treat the cells with imatinib, this is the number or the percentage of viable cells here. Not a lot of cells are dying, but when you treat them with this bortezomib drug, a lot of cells are dying. While we wanted to bring this, both of the drugs, actually, the mithromycin A and the bortezomib, into the clinic, focusing on bortezomib now, bortezomib has some problems in the clinic. It has a bunch of adverse effects. It is an IV medication and has been shown to have somewhat low efficacy in solid tumors. So we went ahead and tested an array of second-generation proteasome inhibitors, so same mechanism of action. And this is just a list of the ones that we tested, and we tested them in comparison to bortezomib. And one of them stood out, this compound called belantamab, and this was just as good as bortezomib. Again, in an in vitro model in a cell line. This is another imatinib resistant cell line where this drug works really, really well. And we even took this into a in vivo model, so in a mouse GIST model, and we can see that belantamab shrinks the GIST in that mouse. We can also see some pictures here. So I have been working with Dr. Burgess to actually translate our findings into the clinic, and we are in the process of applying to the NCI for a clinical trial. So now what about the protein translation machinery? I've shown you, okay, we can inhibit transcription. That works in our GIST models to lead to GIST cell death. Does our hypothesis to inhibit protein translation, so the step from mRNA to protein, also work? And for a while, this was not we were not able to test this because there were no compounds available that actually do this. But this compound called homoharentonine or Cinribo does just that, and it is FDA approved for the treatment of imatinib-resistant chronic myeloid leukemia. And it so happens that this is that type of leukemia where that we also treat with imatinib. So the GIST and CML are molecularly very similar. So we tested this in our cell line model, and first of all, we could see that HHT, as we abbreviate the drug here, really leads to a reduction of protein synthesis in our imatinib-sensitive and imatinib-resistant cell line models. It does lead to a drastic reduction and really correct reduction of KIT protein that is being made, and it also kills drug-resistant GIST cells. We also took this drug into the mouse model, and we could show that it reduces tumor size. So all in all, these are pretty reassuring data that we have, and you may have noticed that almost all of the compounds, all of the drugs that we have been working with in the lab are already FDA approved. That means for other tumor entities. So that means that we can cut out, if you want to bring these drugs to the GIST setting, that cuts out some of the clinical trials that we have to do. So we can start with a so-called phase 2 clinical trial sort of right away. So in conclusion here, it is possible to target KIT using drugs that reduce protein expression, specifically inhibitors of gene transcription and also inhibitors of protein translation. And our next step will be the initiation of clinical trials. So let's switch to the second half of my talk to touch on cognitive impairment in GIST patients. And I already mentioned that this is done in close collaboration with Dr. Ferguson, who is in the behavioral cancer control program here at Hillman Cancer Center, and who's a psychologist. So what is this? So everyone has heard about chemo brain, chemo fog, and essentially this study was initiated, inspired by the patient population that I've been over the past 20 years I've been in touch with very closely. And in analogy to chemo fog, chemo brain, there's always been the complaint that I have BVAC brain. However, this has not really been studied at all. The terminology, this is what we're using in our research just to introduce this term, this cancer-related cognitive impairment, because currently there's a debate what contributes to this cognitive impairment. It may be the actual therapy, but some of it may also come from just the fact that there is a tumor in the body of that patient, and the tumor can release substances that could alter the brain and cognition. Anyway, so to introduce cancer-related cognitive dysfunction a little bit in more detail, this was first described in the 1980s and affects about half of cancer patients at more than 1 year post-diagnosis. But one has to say as many as 40% of those demonstrate cognitive dysfunction at a baseline. Also, cancer-related cognitive dysfunction is often confounded by pre-existing conditions such as age, education, IQ, neurologic impairment, depression, anxiety, and others. It is usually mild and not necessarily progressive, but it can be long-term and bother the patient. This cognitive dysfunction can affect different memory and attention areas, so-called domains in the psychology world. And I'll touch base on these really quickly. So maybe this is something to review later in the recording. So this can be verbal memory. So what is that? Remembering words in a conversation, remembering names, tip of the tongue syndrome. So you realize already, I mean, everyone has this. It's not that you once in a while don't remember a word, you have a cognitive impairment, but it's just the frequency and how much it bothers you, how often you have it, how much you have it, that we then would diagnose it as an actual impairment. And this is the same for all the other so-called domains, such as working memory. So, which is, for example, remember why you walked into a room, or skipping a step in a task, or trouble remember a phone number long enough to write it down. Other domains affected are attention. So you have trouble following conversation, especially if it's in a group setting, forgetting to make a turn by driving, being easily distracted, or having trouble staying on task. And then also there's processing speed. So you can't do stuff quickly, like simpler arithmetic, or you freeze when you're faced with a sudden decision and you have a slow reaction time. So how do we measure all of this? Much of this comes from so-called PROs, or patient-reported outcomes, but also, so essentially there's a questionnaire and you're being asked questions and you just answer the questions, and then we would do the standardized scoring or neuropsychological testing. So these are actually objective tests that test memory performance. And although these are sort of the gold standard, they're really globally, there is no gold standard for the measures. You probably have to use both because it's interesting that there's actually often a disconnect between those two, between the self-report outcomes and the objective tests. So it can be that you're really bothered by something, but then in the actual testing, you're not doing that badly. It is also to note that important to note that the data on cancer-related cognitive impairment is limited to the more common cancer types, specifically breast cancer. And just as today, predominantly female participants, it seems a common theme that females are more amenable to take part in those kind of studies. There's again, limited data on other entities, and there's really very limited data on just patients, and in fact, limited data on kinase inhibitor treated patients in general. Just before we go into our study, let's briefly touch base on what causes cancer-related cognitive impairment. And I essentially touched base on that already. It could be the actual treatment where chemotherapy, radiation, or hormonal therapy, but we don't know much about tyrosine kinase inhibitors. It could be the cancer itself releasing molecules into the body. We know that there's a genetic component, and it could be stress. So what did we do? We launched a web-based survey on cancer-related cognitive impairment in GIST patients that was distributed globally, essentially, just through social media website with the help of the Live Tract group, two other support groups, and in Europe through the Spain group. And so what we asked was a sort of basic demographics and medical history, especially treatment history pertaining to GIST. And then this was based on patient-related outcomes that focused on the cognitive function of the participant and its impact on the quality of life, as well as some more general items looking at anxiety, depression, fatigue, sleep disturbance, and pain, as well as this is a sort of general health measure and a total of 135 questions. This ran for 3 months, and we had almost 900 patients initially sign up for the study. This was, of course, anonymous. We had almost half of them actually completed the study, meaning that they completed more than 120 items of this study. So we are now done with evaluating our studies and are ready to submit our paper. So let me go through our these results really briefly. So just looking at the baseline measures here, so how many people did report cognitive impairment or perceive a cognitive impairment? And it's and what were those scores? So the mean score for cognitive impairment was 35 with a maximum score of 72. And this is depicted here for all of our GIST patients. And this is essentially highly comparable to what breast cancer patients report. So they report a score of 30, so a little bit less. So in this measure, the higher your score, the less your cognitive impairment is. So it's kind of reduced by half, which is quite a bit. However, what is interesting is how does this impact the quality of life, this perceived cognitive impairment? And it's important to know that here the mean score was 7.7 with a maximum score of 16. I'm not showing a graph for this, but a score of 10 and less is considered clinically meaningful low. And almost 2/3 of the patients reported a score of 10 or less on this impact on quality of life scale. That means that 2/3 of GIST patients have a cognitive impairment that has an impact on their quality of life. We thought that this is pretty high. And if you actually now take a little bit of a closer look and divide the patients into the group that has a low impact on quality of life. So those patients that those do not report much cognitive impairment, and this is those patients here, and they apparently fare fairly well. but the patients that report a low score and have a high impact on the quality of life report a high amount of cognitive impairment. We then looked a little bit further and asked what other measures does the perceived cognitive impairment correlate with. And it was quite interesting because it did not correlate with anxiety, depression, fatigue, sleep disturbance, or pain interference. And this is in contrast to what has been described for most other malignancies. However, when we look at the group again that had reported a high impact on the quality of life, those did report significantly worse fatigue, more physical limitations, and a trend to more sleep disturbance. So then we looked at whether the perceived cognitive impairment actually correlates with just therapy. And what was surprising to us is that it actually did not. It did not correlate with current, previous, or prior imatinib, and it also did not correlate with other tyrosine kinase inhibitor therapies such as sunitinib or Regraphenib. While this was surprising to us, we did see that the patients that are on current imatinib therapy did report more fatigue and physical limitations, and the ones that are on were currently on other therapies reported the same, and as well also a higher level of depression. So why is this? We actually do not know yet. Again, there's a caveat to this. This is all self-reported. We do not have any objective neurocognitive testing for these patients. We also have not done an actual exact chart review. Obviously, this is also all reported by the patients. We have no way of verifying if what they told us is true, although we assume so. So now we know, we are kind of thinking about this could be by the tumor, but there's more research needed to kind of sort this out. What was interesting and to note, though, is that patients that are 5 years and more since diagnosis, they reported a significantly worse cognitive impairment. However, and this was interesting, lower anxiety and lower depression. So it is not the therapy in our study, but actually the time since diagnosis that is correlated with the occurrence of cognitive impairment. So in conclusion, this was the first large study on cancer-related cognitive impairment in the GIST and sarcoma population. It demonstrated feasibility of web-based studies promoted entirely by patient organizations on social media and email. We found that 2/3 of the patients report significant impact on quality of life effects on long-term cognitive impairment. Self-reports of cognitive impairment appear to be independent of age, type of kinase inhibitor therapy, or any therapy actually, fatigue, pain, sleep, difficult, and emotional distress. However, survivors 5 or more years since diagnosis report worse cognitive symptoms. And again, this is independent of the therapy. So it suggests some sort of cumulative effect of continuing long-term treatment or long-term metastatic disease in some way or the other that we have to look at in more detail. Generally, results are comparable to research with breast cancer survivors. So we're really just to validate our studies that we are not completely off. But in the end, further investigations with objective measures is needed to really monitor the neurocognitive impact of the disease and the therapy and which individuals may be at greater risk. So with that, I'll end and thank everyone who was involved in all of the research that I did present. But as you may remember from my introduction, there's more. So we want you to directly participate in our research. And as I mentioned already, there are 2 ongoing studies here at the University of Pittsburgh UPMC Human Cancer Center, where we are actively enrolling. No travel is required. These are all telehealth studies, either over the phone or video calls or self-reported outcomes online. And look, see whether you may be interested in one or the other study. The first one looks at the longitudinal assessment of cognitive impairment in GIST patients on tyrosine kinase inhibitor therapy. But here we are looking for newly diagnosed GIST patients that have not started or just started imatinib therapy. So if you are a newly diagnosed patient and have not really started your therapy, surgery should be fine as far as I know. Please contact me. This study includes cognitive assessments, and these are self-reported online assessments as well as actual neurocognitive testing over the phone every 3 months over the course of 1 year. And in our second study, we are actually looking to help the patients that have been on therapy already and that present with cognitive symptoms that complain about cognitive impairment. So here we're looking for just patients that are on current TKI therapy for at least 1 year and that have those cognitive complaints. And what we're offering here is not only the cognitive assessment, kind of similar to what this study does before a therapy, but we're offering a treatment called Memory, Attention, and Adaptation Training, MAT, that was developed by Dr. Ferguson and has been tested in breast cancer survivors and has been shown to be successful in helping them with their cognitive issues. So these patients would undergo a course of this therapy. Again, it's over the phone or a video call. This would be 8 weeks of the treatment. And then after the treatment, there would be another assessment of the cognitive impact on this. So if you're located in Pennsylvania, you don't, again, no travel required, not necessarily have to live in or near Pittsburgh. Please contact me and we could get you screened and consented for this. So thank you for your interest. And yes, I'm also open to questions.
I have a question. So is this study only for PA patients located in PA, or is it open to all GIST patients?
Yeah, great question. Unfortunately, we right now we only have IRB approval for Pennsylvania.
Okay, thank you.
I'd just like to add that if anyone is not writing the address down now and after this is interested in connecting with Dr. Dunsing and participating in the study, just reach out to us and we'll connect you.
Right, and I get a lot of questions about my email address. This is the correct email address without that G that is usually in my last name.
Okay.
Okay. Well, thank you so much. We will move towards Denise Montoya, who is director of our patient registry, and she's going to be sharing some interesting information. So I'll pass the torch over to you, Denise, and we'll have a Q&A at the end. If there's a burning question that pops up in the middle of the presentation that needs to go to Dr. Dunsing or Dr. Burgess.
Thank you, Diana, and pleasure to be in today's meeting. Can everyone see the screen and the presentation? Okay.
Yes.
Great. So hi, my name is Denise Montoya. I'm the patient registry director of the Life of Group. During this presentation, I'm just going to talk a little bit about our registry and our tissue bank and how the Life of Group continues to do their goal and mission to help patients, but with the patient registry. So about the registry, we're the largest patient-reported registry in the world. We have over 15 years of data and close to 35 years of patient history. As you may know, GIST is relatively new compared to other cancers. Therefore, some patients in our registry were misdiagnosed with a different cancer prior to having a GIST diagnosis. The type of data we collect demographics data, we collect diagnosis detailed data, and anything that really encapsulates what GIST is in the whole journey for the patient. We are an IRB approved and a HIPAA compliant, so privacy is priority in our registry. We understand that it's a patient-reported data, but we do have a quality control in place in-house. We also ask for a copy of the reports for CT scans, for pathology mutational, not only to help the patient understand the reports, we walk through the whole reports with the patient, but we also want to ensure that the data provided by the patient needs double checked with the reports. So our aim, as I said, we're an IRB approved research study. Our aim is to understand natural history of GIST. We follow clinical and treatment outcomes. We accelerate research with real world data from patients, and we connect to patients to GIST specialists. It's something that we always highlight as soon as we have our membership calls. We ensure that every patient, if they have access to seek an opinion of a GIST specialist. And we also help patients and caregivers navigate this journey. So I like to always show this picture. This was our Live Fest, I think 2018-19 in Miami. And we have the opportunity to meet with all patients and all GIST specialists and doctors. And we had the GIST Do It walk. It was such a great opportunity to meet and engage in a GIST community. And we're having another one next year, but I just always like to share that because it really encapsulates the mission of the Life of Group, which is helping patients and connecting with doctors. So just wanted to share that. The Life of Group Patient Registry has a global reach, and also as an organization, we have we cover almost 50 countries. We have different groups that we work with to ensure assess on all the needs for GIST. So a little timeline on the patient registry. The patient registry started back in the year 1998. Our executive director, Norman, his wife was diagnosed with GIST, and he understood that the idea of collecting data and understanding all the traits on GIST was important. So he started with index cards on his kitchen table, and then they were part of the clinical trial for Gleevec. So he connected with more patients, and then they started collecting data, and he started seeing the importance of this. So that's when the registry was established. Then it went from note cards to Excel to now a SQL database that has more than 2,000 patients. So it's just a development of the Life of Group registry over the years. So joining the registry, there's 2 different points. So for patients, they submit an application just to be a member of the Life of Group. They provide with the history of GIST, any updates. And then constantly we just follow up with the patient just to ensure that any CT scans, any treatment changes, and then they also have the opportunity to join our tissue bank. And of course, for staff, we send the informed consent. We always continue to engage with the patient to ensure that any questions are answered and connections to the specialists are made, any connections with mentorships. So we are in a constant communication with patients. The benefit for patients and caregivers is they have access to data. They have insight into patients' outcomes. They connect to the specialist. We track symptoms and quality of life of side effects on our registry. As it was mentioned in the previous presentation, the importance of side effects and tracking. We also have resources to conversations with the medical providers. We personalize assistance in understanding clinical reports. We help to guide risk assessment, mutational testing service, and we also to provide unadvised guidance with patterns observed in data from the registry and also from research that we see outside in the GIST world. So we also have the ability to do surveys, and I think this is a great tool. Outside from what we collect in the registry, there are topics that they emerge with GIST developing. So we use surveys as a tool to analyze different topics and to engage with the community. Another great thing we do with the data it's collected, we present any impactful data, any cases. For example, this case of a 35-year-old female, she was pregnant and they were doing the whole sonograms and they kept seeing the baby, and then they thought the baby was just big. It happened on the C-section that the baby wasn't big. It was a tumor that was kind of like confused by the size of the baby. And they tested it. The patient the mutational report showed as wild type. And then the patient already started imatinib and then has to discontinue imatinib. Then advanced testing, which is also encouraged after having a wild type mutation, in fact, showed that it was a KIT exon 11. It was just a misinterpretation or a missed gene in the form of the test, and the patient resumed imatinib. The tumor was very large. It was 15 centimeters. After the patient resumed imatinib, the tumor shrunk drastically. So the importance of testing. Also, it's important to highlight in between that, the patient joined the LifeRF group, connected her to a GIST specialist. That's when the advanced testing was performed. So again, the importance of a specialist, the importance of advanced mutational testing. It's just highlighted in these cases. So we do this constantly. We have different platforms to connect with other experts, but we do also perform virtual tumor boards where we invite GIST experts to review cases. So just a little highlight on the treatments. They were mentioned in previous meetings as well, but I just want to highlight the reports on the side effects that patients tend to report in different treatments. So for example, the most common one in Gleevec, we have edema, fatigue, cramping. And also for Sutin, the most common one is hand and foot syndrome, And then for Quinkluck, we have hair loss. It's the most reported side effect. And then for Avapritnib, we have some cognitive issues, weight loss, dizziness, and nausea as the most common reported from patients. So the mutational testing rate. So it is known to be about 20% in GIST that these patients have mutational testing. In our registry, we have a higher percentage, 54% of patients know their mutation. We suspect that this is due to the connection to a GIST specialist, and also because patients that join the LifeRF group tend to be more proactive than patients that are not joining advocacy groups or connecting with other GIST groups. So that's why there's an increase of mutational testing. So now this is just a summary of all the mutations that we have in GIST. The most common one highlighted here was presented also KIT and PTGFRA. So I'm not going to go too much detail on that, but we did want to highlight the time that we analyze. Okay, so we have a high rate of mutational testing. Let's highlight how long it takes a patient to have access or get mutational testing since the moment of diagnosis. The average was 1.5 years in the LifeRF group since diagnosis. Usually another bias is that our patients tend to be metastatic. Upon diagnosis, we have a higher risk patients. Therefore, you can see a higher rate of testing and also a shorter time to get mutational testing. This is from data from the registry, just a summary of the different mutations we have. Again, KIT and PTGFRA, the most common ones in our patients, KIT being the most common one, and then we do have KIT exon 11 as the most prominent among all the KIT genes. So now, precision medicine, I'm sure everyone has heard these more and more, not often in GIST. Mutations and treatments are now tied together. And I think this is very important because it does highlight the reasons of why getting mutational testing, because it definitely helps doctors and treating oncologists to guide on the treatment plan and assure that the treatment plan for the patient, it's the right path. Here is just a little description of the different mutations and kind of the approved treatments for for some, and some of them in clinical trial or where we have seen some type of response. So the importance of mutational testing. In the registry, we saw the higher number and we wanted to investigate more, like what's the importance of having mutational testing? So as you can see, we have here patients that had mutational testing and patients without the mutational testing. In this graph, you can see that the overall survival of patients with mutational testing and the patients without mutational testing, it's a huge difference. So patients with mutational testing tend to have a higher overall survival than patients without mutational testing. I feel like this is really important to highlight on why mutational testing it's crucial for patients. Now we then saw that trend and we're like, let's see on patients that are metastatic and advanced patients. And we saw the same pattern as well. So patients with known mutations tend to have a better outcome than patients without mutational testing. So I do want to highlight that the Life of Group is right now collaborating with Bayer, and we are offering free advanced testing to all patients. We have a partner lab, which is Tempus. It's only for US patients, but it's anyone that haven't had a mutational testing, or if they had a mutational testing that showed up wild type and they would like to expand it to analyze more genes. It's no cost. We're just trying to really increase testing. So if you have any questions or know anyone that doesn't have mutational testing or doesn't have access to get mutational testing, please let us know and we'll be happy to connect with them. This is just a little image of how now with testing and really understanding mutations, it's driving the patient to a precision medicine path. Thank you. Sorry, I will stop sharing.
Thank you, Denise.
Thank you, Diana.
So we're just going to open up and see if there are any questions.
Denise, that was a fantastic presentation, and maybe I'll just start off with a comment, just a general comment, which is kind of interesting and just kind of stressing the whole mutational testing. So obviously, if you're a doctor and you know something about GIST, like you're sort of educating all of us, you're going to get mutational testing. But what's interesting is that something that patients may not know is that when somebody is diagnosed with a GIST tumor, when it goes to pathology, it's actually not a reflex that happens, at least especially in our institution, but probably in many other institutions across the world. So they will do some special stains on the tumor to diagnose the GIST. And then, but a lot of times it's very important that the physician actually knows to actually request it. So it's not an automatic thing. And I just wanted to bring that up, is that so oftentimes my approach is that patients, when they're first diagnosed, and whether they're metastatic or not, I will approach the pathologist and actually ask for that tumor tissue to be sent. Now, at the University of Pittsburgh, every institution has a little bit of a different policy. But at our institution, we actually use a well-defined panel at the Oregon University of Health Sciences. So basically, that panel will test for some of the major things like KIT and PDGFR. But if that comes back with no mutations there, I definitely will reflex to ordering something like Tempus or Foundation Medicine or Caris to look for a more broad panel. But I just kind of wanted to bring that up, that it's definitely something that a physician would have to ask for.
Yeah, thank you, Melissa. And I want to quickly add, if you remember that I just highlighted the heterogeneity of the tumors and different results that could come out of the testing. This is, I think, more of an issue in the progressing disease after imatinib. I think mutational testing is really highly important when a patient is first diagnosed, because we really have to know whether the therapy even works. You have to know, is there a PDGFR alpha mutation versus a KIT mutation? is there no PDGF alpha or KIT mutation, and this is a so-called wild type or SDH mutant tumor. So then we can kind of skip the therapy altogether and really have another path of treatment. Unfortunately, I do have to say that still some doctors, even some of those that are highly involved in treating just patients, some are still under the opinion that initial mutational testing is not necessary, and they would just start the patient on imatinib, and if it's not working, then they'll test. I don't necessarily recommend that, but those doctors are also out there. So it might be possible by an educated patient to persuade those doctors.